All right. Well, why don't we get started? Welcome, everybody. So great to see all of you in person and hearing all of the energy and the robust conversations. Um, Welcome to Education Day. We are here to celebrate everything about education, the scholarship, our mentors, our educators, and everyone who supports education in the department. I want to put a big shout out to our education committee who has planned Education Day. Laura Zakowski, Amy Zelensky, Catherine Vaughn, and I know there's a whole host of people on the committee. So thanks to all of you. We have a very exciting day ahead of us, a lot of interactive sessions. We've changed the format a bit this year, and hopefully it'll be even better than in past years. Great posters coming up after grand rounds and after the awards. And of course, plenty of food throughout the day. We'll see if there's enough Diet Coke, but it remains to be seen. And for those of you online, if you haven't registered, you're welcome to come by to any of the activities later today. Not a problem. Um, we're going to start with grand rounds. Very exciting. And to introduce our special guest speaker to kick off Education Day is Dr. Laura Zakowski, our Vice Chair for Education for the Department of Medicine.
Thank you, Lynn. Good morning. And I also want to have a shout out to all of our education staff here who are helping with Education Day, make our lives better, keep us in line, and please thank them as you see them at the registration table in the room here and also at the workshop. So thank you very much to everybody. Well, I want to welcome Dr. Sonja Raaum back to UW. Dr. Raaum is our grand round speaker today. She obtained her MD degree here from UW. And then she completed her residency and chief residency at University of Utah. She is there right now as an associate professor in general internal medicine, and she also precepts in clinic there. She is a faculty advisor for the Gold Humanism Society and the course director for the Phase 4 Advanced Internal Medicine course. She has an active grant in collaboration and case-based learning with community health workers through the ABIM. She has many journal publications, has presented many workshops and abstracts at national meetings. She has completed the Applied Compassion Training at the Center for Compassion and Altruism Research and Education at Stanford University. And a very impressive recent honor is a Peer Recognition Award for Excellence in Educational Leadership. This is because of excellence in quality, quantity, and impact of her teaching. Thank you, Dr. Raaum, for traveling to Wisconsin and being part of our Education Day.
Thank you so much. It's such an honor to be here and a wonderful treat to be in Madison. So I have no conflicts of interest to disclose other than, as Dr. Zakowski shared, being a Badger. I want to start by sharing a little bit about my journey in medical education. So after completing my medical degree at Wisconsin, I went to the University of Utah for my residency in that chief medical year. I joined faculty as a hospitalist and took on medical education roles as an associate program director and course director for advanced internal medicine. And my interest early in my career was really around competency-based medical education, this idea that we can define the behaviors that we anticipate are needed to practice independently. We can evaluate them and assess them and really prepare our learners to be independent, fantastic internal medicine physicians. And then we all know that 2020 happened, and that changed a lot for a lot of people. For me personally, the week between Christmas and New Year's was the hardest week of my professional career. I picked up a busy inpatient service. I was working with one resident. The complexity of the cases that we were seeing was astounding. And despite making the best medical decisions we could, 4 patients passed away. And that was huge, but it almost paled in comparison to the suffering that we were seeing people come to the hospital with. that they were disconnected from their loved ones. They had their social support systems entirely drop out, and they seemed like they were getting lost in the system. So as an educator, at the end of that week, I met with my resident and we were talking about this. And they said, and I don't blame them at all, they said, that's not a luxury I have to think about. I just need to put one foot in front of the other to get through. In my role in education, I really want to make sure that people are prepared to practice, right? And so this left me wondering, how can we create an environment where learners, patients, and our faculty can find that joy and beauty in what we do? Because there's a reality that when we practice medicine, we have proximity to a lot of difficulty in people's lives. And so what I'm here to talk about today is that I think that compassion is a wonderful answer to that question. And I want to share what it is, how important it is in healthcare and the importance for patient outcomes, and then help you all think about some ways that you can cultivate that in your clinical environment. So let's start with what it is. The literal definition of compassion comes from Latin and means being with suffering. Interestingly, this shares the etymological roots of patient, meaning the one who suffers. So on some fundamental level, when we're practicing medicine, this is our calling, that we're with the one who suffers. As a construct and practice, compassion consists of a couple key elements. The first is this sense of interconnectedness, that we're all living beings on this planet connected through that experience. Part of that experience is that we all have suffering in some form or another, right? There's big suffering, little suffering. It's really any experience that is not as one that we would prefer. And there's always pain associated with that. What compassion asks is that we recognize that and that we're motivated to take some action to alleviate it. And it's not about entirely getting rid of it. It's about turning towards it and offering a little bit of comfort. In healthcare, the definition of compassion adds a little bit of a layer here, that we're going to show some sensitivity to understand that person's suffering. We're going to combine it with a willingness to help and promote the well-being of that person, and really trying to find that solution to the situation that they're in. What I love about the concept of compassion is that there's a lot of increasing research around how this is literally part of our brains. So it's part of a group of behavior called prosocial behavior. These are behaviors that evolved to allow our species to thrive by caring for each other. And because of that, there is a structural component. We have neural networks in our brains that we can tap into to practice compassion, and these are associated with reward networks. And there's neurotransmitters that are released that help modulate that response to suffering. So basically, if we're practicing compassion, it actually transforms suffering for not just the person in front of you, but the person who's practicing compassion. And because there's this structural and chemical component, it is adaptable. It is something that can be grown through training. A good example of that is this study that was done by Dr. Klemecki, looking at the difference between kind of pure empathy training, which would be like feeling what a person feels, versus compassion when we are encountering suffering. In this study, they took two groups of volunteers. The first group underwent empathy training and then compassion training, and these were about 4-hour workshops and seminars. And then the second group underwent memory task training, so they had to memorize things in a sequential order. And then these volunteers had 3 fMRIs performed while they were watching a video of somebody describing a really difficult situation that they were in, that they were suffering with. And they did these before the first training, after the first training, and then after that second training. And it illuminates that if we are just purely empathic, just feeling what others feel, like I feel your pain, I feel that suffering, that it actually taps into negative affect and activates parts of the brain associated with pain. But if we combine that with that action, that turn towards addressing it, so may you be free from your suffering. This actually reversed the negative affect for those participants and activated the part of the brain associated with reward processing and that social behavior. Now, I know we probably all have a lot of emotional responses when we think about suffering. Empathy is just one of them. And empathy can be thought of, as seeing things from the other's perspective, non-judgmental, and it can be a wonderful stepping stone towards that action. But it's important to recognize the scope of these emotional responses can take other flavors. So sympathy, pity can also come up, where you add a little bit of distance between yourself and the person that's suffering. And it's normal to want to minimize and avoid this. It's a difficult thing, right? To be suffering. That's hard. So minimizing or avoiding, or the very human response of just comparing only from your own experience. In medicine, I think we add a couple additional emotional responses through our training. So judgment can come up, right? Getting fixated on feeling that the person should be in a better place than they are, or immediately wanting to just jump in and fix it, right? And it's a valid response sometimes. As an internist, I think I'm particularly, maybe you all are as well, of going to this place of analyzing and really just trying to figure out exactly why something's happening or why that person feels that way. Occasionally, when these emotions are really big, it can lead to things like blame and shame and just feeling flawed, unworthy of that belonging and connection that is so key to being human. And it's normal that it can activate a stress response. So if that happens, typically it's more of a freeze, like a sense of overwhelm, of helplessness about what you can do when you're encountering somebody going through such a difficult thing. I highlight these because we've all probably been on the receiving end of this sometimes. We've all probably been the person who's giving that sometimes. That's the response to suffering. But once we can recognize that it's normal to have a breadth of responses, once we can recognize them, then it offers an opportunity to move towards compassion. All right, so hopefully that lays a little bit of that groundwork about what compassion is as a practice. But what does it look like in healthcare? Prior to 2015, a lot of the literature on compassion focused primarily on behaviors that would be considered compassionate, and they show significant benefit for patients. So if an anesthesiologist sits down with a patient and explores their concerns, their worries prior to a procedure, it can lessen the need for sedation and decrease response to painful stimuli. As internists, if we can sit down and explore patients' difficulties with their management of diabetes, it improves medication adherence and glucose control. As physicians, if we can verbalize for a patient a difficult emotion that they are displaying, it's actually associated with shorter visit time. And training an emergency department team to respond more compassionately when asked to do things outside their typical scope of practice actually decrease inappropriate use of resources in the emergency department. More recently, there are questionnaires that patients can answer to provide their sense of how they're perceiving receiving compassion. And then these questionnaires can be correlated to outcomes. This study from 2024, which is a large set of patients that went to the emergency department, showed that the patient rating of compassion was the variable with the strongest prediction of overall quality of care that they received. And it explains 65% of that variance in the ER. If you're interested in understanding more about the data behind this, this is the thesis for the book Compassionomics by Dr. Tresiak and Dr. Mazzarelli. And they start with this key fact that the vast majority of Americans are going to prioritize kindness in their treatment above many other key considerations in their care. At an organizational level, we also have placed an emphasis on this, and there's some benefits. So hospitals that place value on compassion by supporting their team members to be compassionate have higher patient-related reported outcomes of HCAHPS scores. And if you look at the top 10 hospitals and clinics currently in the US, 7 out of those top 10 have compassion listed as part of their mission, vision, or core value. And I just wanted to note that this institution does too, right? It's so wonderful. Commitment to serve through medical innovation and unparalleled compassion. It's also true that there is a gap in practice. So just over half of patients and physicians say that the healthcare system can generally provide compassionate care. And on more of a micro level of what's happening in a visit, physicians are probably missing many of those cues that our patients are providing about their difficulties. In this study, responding to those cues was only happening in about 1/3 of visits. So why might that be the case? I think it's important to recognize we are all human, and so there's a typical response that we have to kind of work through when we encounter suffering. And the psychology literature helps kind of define this. So the first thing that we may be thinking about is who is suffering. If it's ourselves, sometimes it's hard to tap into a compassionate response, and sadness, anger, and shame can come up. But we're here to help others, so we quickly move to these other questions. If someone's suffering satisfies some goal for yourself, it would be normal to let that happen. I think that's obviously a rarity in medicine, but it would be normal to let that happen. But in medicine, we're here to help. We're going to move to this next question. Is this person deserving of help? And again, I think we can all make the assumption that we want to help, but this is where unconscious bias, explicit bias can come up and disrupt it. And if you are being asked to meet that patient's suffering and help them, and you have that come up, anger would be a more common response. But I think generally we probably quickly move to this last question, which is, do I have the resources to cope and help? And that one, I think this is the big crux of the issue. So I remember this op-ed in 2019. Does anybody remember this coming out? Dr. Offrey's. Basically, the idea that we will often go above and beyond again and again at our own expense. And I think that correlates really well to what is going on with burnout and compassion. And it suggests, right, that it's not an individual issue here, that we're looking at systems problems. The first thing that I note is empathy starts to decline as students enter medical school, particularly when they start their clinical training. By the end of medical school, 50% of medical students experience burnout. And the most recent data from the Medscape survey, 50% of internists report feeling burned out. It's important to note those domains there of emotional exhaustion, depersonalization, which is a sense of cynicism towards others. That comes up. And I think that's protective. It's like we're trying to protect ourselves because we want to help, but maybe we're not given the resources to do so. And when that happens, there's another concept to be aware of called compassion fatigue. And this is a little bit more profound than burnout in the sense that there's that emotional, physical exhaustion thought to be due to, the stress of caring for patients who are suffering. And I want to note, I think a lot of the researchers around compassion will say this is maybe more like empathic distress of like, I really want to be able to do something, but I can't. Or this like compassion arrested, of like, I tried my best, but it didn't result in impacting that suffering. It's less well studied in terms of the incidence, but anywhere from 7 to 40% of physicians will experience this. So if we don't have the resources to cope and help, it's important to note that in this appraisal of suffering, this can result in empathic distress, compassion fatigue, secondary traumatic stress. Ideally, though, we work to cultivate those things and we can cultivate compassion. And our satisfaction with that process has a ways to go. Compassion satisfaction is not well studied in physicians. Out of the studies that are present, less than 20% of physicians are reporting satisfaction with their practice of compassion in clinical care. So I think all of this data leaves us with a little bit of what I call a compassion conundrum, that compassion is valued by our patients. We know it's associated with positive health outcomes. Our institutions value it and have placed that value in their mission and vision statements. And if we don't provide the support and skills that are allowing us to cope and help, it will be inconsistently encountered. And it can lead to things like compassion fatigue and empathic distress. So what can we do about that? If you're like me, you may have thought for a long time, at least I did, that compassion was something that you had to be born with, that it was just about the person who was being compassionate. I would look at my attendings and see them and think, oh, it's just, Dr. So-and-so, they're just so compassionate. They were just born that way. It's not something that I can learn. But in reality, compassion as a physician occurs within a whole ecosystem, right? It's not just you, it's clinical factors and the patient factors of like who you're interacting with. It's what's going on around you in terms of the environment and institution. And it's also about what skills you have to tap into that can help foster that innate compassion. So let's explore some of these factors. If we look at personal characteristics that are associated with empathy and compassion, there is a positive association with being a woman, having prior work experience and general maturity, openness to new experiences, agreeableness, or coming from an upbringing that emphasizes compassion. On the flip side, having negative attitudes towards patients or beliefs that value emotional distance may make it slightly harder to tap into compassion. Patient, family, and clinical factors are not well studied, but I think the important one to note here is that if you're able to relate to your patient, that this is more positively correlated with compassion. And this is, I think, very important when we think about our workforce, to have the breadth of experiences, diverse experiences that help us relate to our patients. That's going to strengthen our workforce for compassion. And then in terms of clinical factors, there's really no association. So it's not like if you are taking care of a patient with cancer that you're going to be more compassionate. There's no data to support that. Looking at the external factors, I think offers some opportunities for us in education. The first would be that the data is very consistent again and again, that role modeling plays a huge role in terms of cultivating compassion in an environment. So having positive role models is associated with predominantly higher empathy and compassion in trainees. The second is that if you train in a culture or practice in a culture that only places value on efficiency above other attributes, this is associated with lower empathy and compassion. I think that makes sense in terms of time constraints and workloads. That's where you maybe don't have the resources to cope and help. And then there's a small proportion of studies looking at this impact that as you move through training, desensitization, this routinization of what we do every day starts to build up. And it makes it a little bit harder to tap into compassion. And interestingly, that's also supported if you ask trainees about the barriers to compassion. As they progress, more experienced trainees are going to report more barriers. So I think that suggests that, there's definitely stuff going around in the environment that's impacting that ability, right? I don't think this is the fault of our learners or the individual. One thing that I've been thinking about in education is really, that concept of competency-based medical education. How much have we built compassion into that process? And if you kind of look at these behaviors, sometimes it's hard to define compassion, right? And I think maybe because of that, we don't see it as much in those guidelines from competency-based medical education. So looking at entrustable professional activities, the skills that we want our medical students to have by the end of medical school, compassion is mentioned 3 times. In patient care, communication, professionalism, that's great. But if you look at other ways to describe this, right? Respect is mentioned 49, integrity 27, analyzing 26. So these other concepts, I think I would like compassion to be on the same realm. In internal medicine, if you look at milestones, which are defined by ACGME for general internal medicine residency, compassion is not mentioned. It does address some of the skills that potentially would help, right? Like addressing those psychosocial and determinants of health and mitigating communication barriers, but it's a noticeable lack. In subspecialties, 40% of internal medicine subspecialties mention compassion, and that contrasts to 90% in pediatrics. So that's a little bit of the lay of the land of those external factors that may be impacting compassion in the environment. But what about these skills? In order to develop the skills, I think it's important to look at what a patient will perceive as compassion, and that perception correlates very well with that practice of compassion. That patients are looking for recognition of their difficulty, emotional resonance, and then some action moving towards addressing suffering. In terms of educational interventions that do that, we have a ways to go. So this systematic review from 2021, there are 108 studies that kind of were doing that on some level. 50 of them took place in the United States and a smaller subset that involved medical trainees. And notably, out of these interventions, none had compassion as a primary focus. Most interventions focused on a single domain of compassion, like the communication aspect, maybe the emotional resonance, but didn't combine them. And the study designs could be improved in terms of outcomes for controls and comparator groups. I think that the other area where we see a great opportunity is that none of these translated directly into clinical practice or were implemented in a clinical practice. So if we look outside of medicine, there is a gold standard for cultivating compassion. It's called CCT. It was developed at Stanford University by Dr. Thupten Jinpa. He was the Dalai Lama's primary interpreter and translator for many years and a scholar. And it consists of an 8-week course with didactics, daily meditation practices, real-world assignments for practicing compassionate thoughts. And a randomized controlled trial showed that increased mindfulness, happiness, decreased worry, and emotional suppression for participants. If we can translate this directly into the medical setting, there are 2 studies that have done this so far and been published. At a hospital in San Diego, they offered this to all healthcare workers, and it was an opt-in study. And out of those participants, they had improved self-ratings for self-compassion, being able to provide compassion and mindfulness. And then a randomized clinical trial with medical students at a university in Spain randomized the students to either complete the CCT or to a wait list. And those who completed it had improved self-ratings for their self-compassion mindfulness, as well as emotional regulation and a reduction in emotional exhaustion and burnout, which were good outcomes. So that offers, I think, some opportunity. For us in education, I think our educational opportunity is to think about how do we potentially change or kind of address those external factors that may make it harder to be compassionate and combine that with the skills that are needed. Out of the recommendation for programs like this, it is supported to have leadership buy-in, to make sure that you are working to foster innate compassion, doing needs assessments about what is needed prior to doing that, and then having robust measures and outcomes. So when I think back to where I was in 2020 and trying to start to explore compassion after that very difficult time for me, as an educator, I knew that I needed to grow these skills a little bit more, and that's what led me to go to applied compassion training at Stanford. And what I learned was a framework, and that's what I'd like to leave you all with to think about, this framework that we can use and apply it to both clinical settings as well as what we do in medical education. And the first domain of the framework is a sense of awareness. It's both non-judgmental awareness of what's going on and somewhat of a acceptance as well that, just what is present, what's in this moment. And this is going to allow us to identify opportunities for compassion and opportunities for our own growth. And we can strengthen this through meditation and contemplative practice. And that's why a lot of wellness programs also focus on this and could fit and complement each other very well. In medical education, I think this is a real great opportunity for us to be role models and to think about intentional structure. And so that could look like pauses when we are encountering a difficult moment so that we can all just take, it doesn't have to be long, I'll just take a moment to kind of recognize what is present right now. And then having some kind of routine built in so that this is just kind of the expectation. So at my clinic, we do a morning huddle. Huddle ends with 3 to 5 minutes of some kind of mindfulness. We either do a guided meditation or walking or, some kind of mindful movement. The second domain to think about here is embodiment. And while it seems like this should come intuitively to us because we know the human body so well, this is probably one of the hardest things that we do. It's about being in tune to ourselves and integrating that thought and feeling towards action. And the importance here is that recognizing our physical states impact our ability to emotionally regulate. And that, there's this growing science around the concept of interoception, of like how our body maintains those basic needs and how disruption of that can lead to more serious illness like depression. This is why movement, breath work, yoga, body scans all have a role potentially to cultivate compassion. And the last one on here would be boundaries for both physical and mental well-being. In medical education, I think this is really important for us as educators to advocate to meet basic needs. And I really mean basic. Making sure the team has time to go to the bathroom, that they're hydrated, that they got nourishment. If they have other needs like lactation, that is being addressed. Acknowledging as well and being a role model to show that what we do is very hard physically. If we're on our feet a lot, modeling that we can adapt, right? And recognizing that looks a little bit different for each individual. And then also modeling our boundaries and exploring our own boundaries, because I know that my boundary for emotions is very different than other people. I'm okay being with maybe more difficult situations, but just modeling where that is and helping somebody explore that can be really helpful as we develop in our careers. The third domain is common humanity. That's kind of that underpinning of compassion, that we're all connected through this experience of being on Earth, and that each experience is unique and valuable. And this allows, if we tap into it, it enhances our feelings of connections to others and has been shown in healthcare to be helpful. Practices that will strengthen this are, reflective practice on how you are connected with somebody. And then there's a very well-validated meditation called loving kindness meditation, which really taps into those feelings of connectedness, that on a very basic level, that all of us want to be cared for, that we all want to be feeling safe. In medical education, we can prompt reflection on shared aspects of the patient experience, particularly if we're feeling disconnected from a patient. This can be very helpful to help foster that connection. What is going on here? Our patients want to feel safe, just like us, right? Want to feel connected. And we can also acknowledge that in difficult moments, those general needs are going to be present for that patient and our learner too, right? All of us are trying our best. All of us want to be successful at what we do. The fourth domain is humility. And this is not about being humble. It's more about having a balanced and accurate perspective of ourselves and others. This is really important because our brains are wired to recognize threats and things that are not going right in the environment. So in order to counteract that negativity bias, we need to kind of tap in, make sure it's balanced with what is going well. And by doing so, we can expand our capacity for compassion. Practices that strengthen this would be gratitude, just at the end of the day, thinking about what you were thankful for. Or you can do it in a structured manner. There's this fun exercise called roses, buds, and thorns, if anybody's practiced it. But roses would be the things that are, beautiful, that brought you a little bit of joy. The bud is the opportunity, the thing that's growing. And then the thorn would be the thing in your side that you want to acknowledge. In medical education, this is our opportunity to leverage those positives in face of difficulty. So as a practice, if you are taking care of a patient and they have that very long problem list and it seems to only be growing by the day, that's a wonderful opportunity as a team to think about what is going well and how can we leverage that for this individual. And then having that kind of structured practice of just thinking about reflection of at the end of rounds, just one good thing from the morning for you. And it could look different for everybody, right? The last domain is action. And this is about skillful action, about recognizing there's a little bit of a difference between that knee-jerk reaction that sometimes we tap into versus thoughtfully responding. And it's this taking action that helps alleviate suffering and distinguishes it, compassion from other responses. Practices that can strengthen this, I like to recommend fierce self-compassion. I think it's really important to have a very strong sense of yourself about what you can bring to that action. And then the loving kindness meditation is another well-validated way to do this. In medical education, again, that opportunity to role model and share is wonderful. And also start to share with your learner when you identify the opportunity for action and maybe it was missed, you can share that with a learner as an opportunity for the future. It's also probably important to have some go-to phrases. I like to have these ready so that when something difficult is coming up, that I can tap into that. And sometimes that will be, gosh, I imagine that is really difficult for you because of X, Y, and Z. Or I see how much work you have put in, and it has to be so hard that you're not getting the outcomes that you would expect. The other opportunity is recognizing, the difference between venting and problem solving. And I think my younger learners have been so wonderful to teach me this. And so this is that opportunity for active listening, recognizing that that act of listening is the gift. That's the action. And I know you're all laughing at this cartoon, right? I think is a wonderful way to think about it. The person with the long hair is approaching their friend and there is a nail in their head and they're saying, my head hurts. And of course, it's valid that the person on the right is saying, just pull the nail out of your head, right? But that misses the opportunity. Like, why was the nail there? What is going on with that? You know, what does that mean to that person? And that ability of that person to have somebody to listen to their concern may help them remove the nail themselves and address that underlying issue, right? So what I like about this framework and the reason why I share it is I think it correlates very well to our clinical practice too. So it mirrors somewhat another framework we use every single day, which is our SOAP. And here you would have awareness is kind of that subjective data that we need to gather about a situation. Embodiment can be more of that objective. And then the skills of common humanity and humility are wonderful to use for assessment of a situation. And then action directly correlates to a plan. So this is a good way to memorize it. And I hope it's piqued your interest a little bit because I know it's a quick run through. So in summary, I hope I have helped you define compassion and differentiate it from other reactions to suffering. And I hope that you're able to describe the impact of compassion on health outcomes. And have started to pique your interest about what are the factors that you can leverage to promote compassion in clinical education. As a little bit of a coda, final ending of what this journey has been, back in 2020, I was a hospitalist. I underwent applied compassion training, and I totally changed my career because of it. So I had the opportunity to become the medical director of a student integrated clinic that we have at the University of Utah, and really thinking about how to cultivate that environment for our students so that when they are rotating through and they're learning their basics, that we're helping them early on in their training to cultivate compassion. And it has just been such a joy and so fun. And I also reflect back that really probably started here in Wisconsin in terms of where my journey has taken me. And I just am so appreciative of all of you and what you do here at Wisconsin. So thank you so much for having me. And it's been such a joy. And I welcome any questions, comments, thoughts.
Great, thank you. Although I would be the person pulling the nail out of the head.
Right?
I know, that's the first thing. So I'm going to ask the first question. So when I'm reflecting back on my own training, which was prior to the days of work hour limitations and every third night call, there was a book that was very popular at the time, House of God, which I would say was the epitome of cynicism in medicine. So when you're looking at changes in physician compassion, what, comparing it to that era, pre-work hour limitations, et cetera, have we become more compassionate because of those things? I know personally, when I am sleep deprived, I have much less compassionate. So what do you think has improved to allow us to have more compassion? And conversely, are there other factors at the same time that have made it more difficult, that have impeded compassion?
Yeah, that's a wonderful question. I think the things that have improved that we all have experienced, right, is, our workforce has diversified. And so having women rise through the ranks through that time, I think probably has changed our environment, that we have to think about other factors that are going on, that needs need to be met. And so work hour regulations has changed and probably helped. And then recognizing, how to have parental leave and integrate that into just practicing medicine, right? I think that those are really good things. The one factor that a lot of people will talk about that maybe has negatively impacted is the EMR and being stuck behind a computer instead of a person. So that is something that has been probably negatively impacting. Oh, wonderful. Yeah. Yeah. But then I also think the fact that, in terms of the positives, like the neuroscience behind this being described and studied has allowed to think about ways to kind of more validated ways to cultivate it and progress the science. Oh, wonderful.
I'm going to chime in. I'm
Yes,
Heidi Tweet. I'm an informaticist. There's actually increasing evidence that it's not the EHR, but the things that the EHR mediates.
Yes.
That is the trouble, right? So can you comment on regulations and things like that as a contributing factor to not having the bandwidth for compassion?
Yeah, yeah. I think you're absolutely right on that. That, going back to having the resources to be able to cope and help. If you have a very long checklist of things to complete, that's going to make, compassion a little bit harder to tap into. As you were talking too, I was remembering that there is actually, with AI, this idea of trying to lessen that. And I find it very intriguing that the initial data looks like AI-generated responses are perceived as more compassionate than our written responses in my chart. I think that that's very interesting. And maybe, we shouldn't feel bad about that. That's a potential possibility for us to harness and like leverage that a little bit. But it is an interesting time.
Especially in our system where patients can look at their notes. If there's compassion documented in notes, maybe that helps. I don't know.
Yeah.
But my question is a little bit about compassion fatigue, because I love your framework that you have. And I'm wondering where the resetting and doing over again fits in, because I think you build compassion, and if you don't continue to work on it, it will deteriorate. I think that's probably a natural piece. So I wonder if in that framework there is a piece there that you would identify as the reset or the do again or whatever.
Yeah, that's a wonderful way to think about it. What's coming to mind is like I said, some researchers will call compassion fatigue a little bit of a misnomer. And so switching more towards that empathic distress of what that means is like there's some emotional dysregulation happening that makes it harder to tap into compassion. And I think that's the opportunity for that reset is how can we help emotionally regulate to get over to compassion.
Okay, I think now it's on. Hey, we met last night. It was lovely. So I'm an associate professor here in the Department of Medicine. I get to work with Amy a lot on a course we developed for the residents called the Empathy course, and it's just, words are so interesting, right? So in our course, we do focus a lot on building awareness and embodiment, and then those skill-focused kind of elements of how you respond to someone to show compassion. And we weave into the course a lot of like sort of micro compassion trainings, as well as some humanities-informed compassion enhancing techniques. But I keep thinking we need a new name. I have an idea. We can talk about it later. But in my other role as Chief Wellness Officer at UW Health, I think it's so interesting to think about building systems that support compassion. And you brought up the notion from the medical student focused work about focus on efficiency. I'm sure all of you have seen our well-being model, which up until this year has a domain called efficiency of clinical practice, which is kind of a problematic notion because it suggests something that we have to actively do, like we have to be more efficient. That's not really what's meant in the model, but it can feel that way. And you'll see this year the model has been changed and adopted for our entire system, and it's now called Ease of Daily Work, to identify that it's about building systems that create efficiency such that we can focus on what matters most. And like our informatics colleagues are doing such important work to elevate that around things like ambient listening, for instance, and its integration into our health system to really make it so that we can focus on our patients and have some of that work happen automatically. So I just love this notion of thinking about sort of system. And the question I have for you in that long preamble, and I apologize for that, is how you sort of straddle and navigate the role or the conflict between it's the system. And also there are huge benefits for individuals focusing on compassion cultivation, whether it's self-compassion cultivation, whether it's compassion training for others. We know that it helps, right, when individuals do that. So to me, it's very yes and I'm just curious how you think and talk about that with others.
Yeah, that's so wonderful. I loved your preamble, by the way. That was great. Yeah, so I think, it's really important to kind of that message of when we talk about these things, you're so right. The words are so important and sometimes can be loaded. And it's important for a learner to know that this is not a deficit on their part, right? That I'm here to help you do what you want to do, right? To meet that need of the person, feel empowered, feel good at what you are doing day to day. And, it's that journey is different for each individual in terms of exploring it. And I think that that's the other part of just being open, that sometimes in that initial kind of discussion, it may not land. And then you just kind of keep repeating, coming back to it, showing how it works, having an environment where it's present, and exploring it together. That's kind of, but yes, yes and is definitely the answer.
So I have a question from one of our online listeners, and I'm going to paraphrase it a little bit.
Yeah.
So we all have time constraints in our clinical practice, set amount of time to see patients. How do we fit in? Do you have some specific tools or tips to fit in compassion in a very short time block?
Yeah, I think that study that I quoted about the benefits of explicitly acknowledging somebody's difficulty, that can actually save you time. So that saves about a minute. I know it's not like a lot, but when you have 15 minutes, right, it potentially is more. So just being able to verbalize the difficult emotion that somebody may be displaying, like, I see how mad you are about that, or how disappointed you are. And I validate it, and let's think of some ways that we can move things forward. That's a helpful thing. And then I think the other aspect I would recommend is kind of exploring that boundary. So recognizing that when I'm practicing, what I feel comfortable putting into an encounter and how much I do, like, that's unique to me. And once I can set that boundary, it feels much more comfortable to be like, I've reached my limit. That's okay. I'm going to pass the baton to somebody else to do this.
All right. Hi, I've got a question. I'm Katie Miller. I'm an associate professor in general internal medicine. I recently was board certified in lifestyle medicine. And in lifestyle medicine, we talk a lot about positive psychology, meaning starting the visit with asking the patient something that's going well in their life, or when they're having a hard time making changes, asking them to reflect on a time that they were able to make changes and be resilient. And so I wonder about, how that relates and how we can help patients generate self-compassion, not necessarily compassion for us and our difficulties as a provider, but compassion for themselves and their difficulties, and how that might transform our interactions. With positive psychology, it actually has been shown to decrease the length of the visit by quite a bit, because patients don't feel like they need to go on and on about how hard things are for them.
Yeah.
So wondering your thoughts on that.
Yeah, I mean, I think what you just described fits so well into the domain of humility, of like that fair assessment and having that ability to kind of see completely what somebody is doing, and they are feeling fairly assessed, right? And so I think that it's a wonderful benefit. And I had another thought there, but it just went. Sorry.
Thank you so much. That was wonderful. This might tie together a couple of comments, but one of the things I'm curious about is whether we have any science that talks about the need for self-compassion prior to being able to be successful in compassion for others. And I think it's very interesting. My name is Shobi Cheda. I'm Associate Dean for Medical Education, do a lot of work and thought around medical students, and really around one of the words we haven't said here yet is failure. And I failed yesterday to complete dictating or completing all my charts, you know, and I'm sitting here today, right? And so how do we handle that, and how does that really impact our core to be able to be fully compassionate to others?
Yeah. I think I appreciate you. Yeah, it is okay about the notes. I appreciate that comment so much, that a lot of the training for compassion, you're right, has self-compassion built into it. So I don't know how well, like how strong that data is off the top of my head. What I do know though is, yeah, I mean, it correlates so well in being able to practice compassion and have self-compassion. And just, you know, what Dr. Kristen Neff, who's kind of the forerunner of self-compassion, will say, you know, is talk to yourself like you would talk to a friend. That's what you need to bring. And that makes a huge difference. But I don't know about the competency and self-compassion directly correlating. And that's notable that in the design of compassion programs, that prior self-assessment that at that level is important. But we don't probably have all that data.
I'm also going to paraphrase another question from the audience and add my own twist to it. So you've been focusing on physicians for compassion, but there's a whole team that takes care of a patient, and often the scheduler, for example, is the first person, or the person at the front desk is the first person the patient sees and makes that first impression. So how do we make the whole team or the whole experience that a patient has more compassionate?
Yeah, I mean, that's the team building that needs to happen, right? I absolutely agree. I think start with what you have potential control over and influencing who you are immediately working with and talking about it. At our clinic, our students answer the phone, so I feel pretty comfortable starting to impart that with them. Yeah. Yeah, it is I would say it's one of the harder skills. I'm sure the students in the room are like, no, it is really a hard skill to learn and coach, but if we're in the same room, we can do that together, and that's what we work on. But yeah, it is a team effort, and I think it's an institution effort too. There's a whole nother field of kind of more of a organizational-based compassion, and Monica Warline is the kind of leader of that, and talks about how to literally design organizational structure that's more compassionate.
Great. And my last question is, one of my favorite comments from our burnout surveys that we have done, our wellness and burnout surveys, was from a resident who said, "Don't make me do yoga, just give me free food." So how do you address the different people have different needs.
Different people have different needs. Yeah. It's about meeting those basic needs and doing that assessment. And I mean, as a resident, man, free food was the best. But I will say, you know, I've been thinking about this in terms of gender-based issues in the work environment, and making sure that our learners who are lactating have the resources they need, because that is such a stressful time if they don't, and they have difficulty focusing on what they do. So
but I think I love that idea, like, you know, start at the basics.
Start at the literal basics. Yep.
Great.